Esophageal cancer is one of the most lethal cancers. Its overall survival is like 5%, and even after total resection of the esophagus, survival is less than 20%. This cancer usually targets males than females. It's really a nasty type of cancer. Why? It's not only because of the poor survival. If you notice here, even when you encounter this cancer in your endoscopy, biopsies of the lesion usually fails to recover malignant tissues in like 33%. You can miss the cancer tissue. The esophageal cancer is classified into two main types, the adenocarcinoma type and the squamous cell carcinoma type. In the past, usually this squamous cell carcinoma was more prevalent than the adenocarcinoma. Recently, they become almost equal, and the most updated data shows that the adenocarcinoma is increasing actually. That might apply to the Western population. They have more adenocarcinoma than squamous cell, while in the third world, the squamous cell carcinoma, despite that its the incidence is decreasing, it's still more prevalent than the adenocarcinoma. Regarding the risk factors, the adenocarcinoma takes the same pathway of the Barrett's esophagus and the GERD. So the risk factors mainly are those of the Barrett's esophagus. And Barrett's esophagus is the strongest known risk factor for adenocarcinoma. Obesity remains one of the most important factors, as in GERD as well, and the truncal obesity along with heartburn and reflux, and the presence of the GERD for more than 5 years. Again, male population, especially the white and those above 50, are the least lucky, especially if they smoke. Regarding the risk factors of the squamous cell carcinoma, smoking and alcohol plays a major factor. Just keep in mind that alcohol is a risk factor in the squamous cell type, not in the adenocarcinoma type. Actually, the amount of smoking or alcohol have a dramatic effect on the development of the disease. What we know, the nitroso compounds, the smoked food, also play a major role. Drinking extremely hot drinks, exposure to radiation, and the lye, which is sodium hydroxide, and the caustic agents that lead to stricture. This is also considered a risk factor. Achalasia, for long-standing achalasia for about 10 years or more, may play a role in the development of the squamous cell carcinoma. And the betel nut chewing, which is a kind of fruit they consume in the Far East, also plays a major role in the development of disease. They claim that deficiencies of some elements like selenium, molybdenum, zinc, and some vitamins also are risk factors. Hemopapillomavirus and the presence of whips, especially in the Plummer-Vinson syndrome, also is a risk factor. History of gastric surgeries, also celiac disease, and head and neck cancers are associated with the squamous cell carcinoma. Also keep in mind the entity which is called tylosis, which is a non-epidermolytic palmoplantar keratoderma or palmaris implantaris, also is considered one of the risk factors of the development of squamous cell carcinoma. Biphosphonate are considered a risk factor in patients with Barrett's. So these patients usually should avoid this kind of medications if they already have Barrett esophagus. Before we proceed, just keep in mind that the adenocarcinoma tends to develop in the lower third of the esophagus, while the squamous cell carcinoma tends to develop in the upper two-thirds of the esophagus. Metastases to the esophagus from other tumors are rare, yet just remember that the melanoma, skin cancer, and breast cancer are on the top of your list. Symptoms-wise, these cancer usually present in advanced age. Again, it's really nasty cancer. Usually, unfortunately, the patient usually present late. Around 50% of the patients are asymptomatic at time of presentation. The problem is that the cancer takes a while until it blocks the lumen of the esophagus, then gives these symptoms, and it becomes advanced by that time. So by the time the patient becomes symptomatic, the disease is usually incurable. Again, the main symptoms are dysphagia that is rapidly progressing. Keep in mind the course of the disease is very important. When you encounter dysphagia that develops rapidly to solid then to liquid, along with weight loss, that's grave. There might be other symptoms like pumps, like lymph nodes, supraclavicular lymph nodes, and the Tyloo's, as we said before. Other symptoms maybe the patient might encounter, like a hoarseness of voice when there's involvement of the left recurrent laryngeal nerve. There might be also symptoms secondary to the metastatic disease, which mainly are to the liver and the lungs and the bone. There might be upper GI bleeding symptoms secondary to ulceration or fistulization. The main diagnostic tool here is the EGD with biopsy. And unfortunately, this might fail to recover any malignant cells in 1/3 of the time. In that case, if you're highly suspecting a lesion in the esophagus, that might be a cancer, and the biopsies didn't yield anything, you go ahead and you must do an EUS. Lab-wise, there usually a hypercalcemia, like in most of the cancers, especially the squamous cell cancers. This might be secondary to the paraneoplastic syndrome of the parahormone-related peptide. When you need to stage the tumor, first of all, after you suspect or if you get the cancer of the esophagus, you need to start with the CT scan for staging. PET scan plays a role when there is a mets in the CAT scan. Again, the EUS plays a very important role here when you want to stage a locally advanced disease. Especially when and also especially when the biopsies didn't yield much at the beginning. So if the patient have a distant metastasis, you want to rule out your option is the CAT scan. If you think that there are missed on the CAT scan, you go ahead and request a PET scan. For locally advanced disease, I mean disease without mets, you go ahead and do an endoscopic ultrasound. This is the best option in this clinical scenario. During the staging, you need to apply the Swaity classification of the adenocarcinoma of the EG junction here. Your landmark here is the anatomical cardia or the GE junction. Anything from this landmark and 2 centimeters below are considered or treated as esophageal carcinoma. Anything beyond that, 2 centimeters from the line and down to the stomach is considered a tumor of a gastric origin. So you treat it as gastric carcinoma. Again, this disease is very lethal. The 5-year survival is 5%, and even after surgery, it's less than 20%. How we manage the esophageal carcinoma? You stage the patient as we see here on the left. TIS is what's called high-grade dysplasia or carcinoma in situ. They no longer use this term. T1 is the tumor confined to the mucosa and the submucosa. When it's in the mucosa, they call it T1A. And there are three subcategories here: M1 in the mucosa, M2 in the lamina propria, and M3 in the muscularis mucosa, not muscularis propria. And T1P is when the tumor is confined to the submucosa. Remember here that there's a sub-classification here that is used. You use SM1, which is submucosa 1, with well-differentiated cancer that we'll talk about in a minute. When it reached the muscularis propria, it's called T2. When it reached the adventitia, it's T3, and T4 when the tumor invades adjacent structure. Subclass A or B, it's either the tumor is resectable or unresectable. Okay. So how we do proceed? The TIS or the high-grade dysplasia and T1A or T1B only SM1 with well differentiation and no lymph nodes. These patients you can use endoscopic treatment in the form of EMR and radiofrequency ablation. Surgery is still the option, especially if you encounter the SM1 well differentiation. If you reach the level of T1B, that means the tumor has reached the submucosa, EMR is no longer working unless it's SM1, but usually surgery is the preferred way. Also T2, which is tumor in the muscularis propria, surgery. When it's T3, that means the tumor have reached the adventitia. Let me give you some tip here. When it's adventitia, you have to add something to the treatment. So it's not only surgery. You're gonna give pre-op added chemotherapy and radiotherapy, then you proceed for surgery. Beyond the T3, also the patient might receive a neoadjuvant chemotherapy and radiotherapy, then surgery. When the disease has become metastatic, there is no rule for surgery. It's only chemoradiotherapy and plus or minus stenting, depend on the dysphagia. Just remember here that if the tumor is surgically resectable, yet the stage required chemotherapy and radiotherapy, and there is dysphagia, you might place a fully covered, why fully covered? Because it's temporary, esophageal stent, until you know what you're going to do with this patient. Basically, we won't place an esophageal stent unless the patient has unresectable tumor along with dysphagia. You never place a metallic permanent stent for someone who doesn't have dysphagia. For palliative reasons, sometimes the patients don't tolerate the placement of the stent. In that case, brachytherapy, it's a type of radiotherapy, is recommended. So if the patient isn't a candidate for a brachytherapy, you go ahead and place a stent for that patient. The problem with the covered stent versus the metal stent is that the covered stent tends to migrate more. Again, quick summary: high-grade dysplasia down to T1B, SM1 well differentiated only, EMR plus ablation. T2 is only surgery. T3 is surgery and adding the pre-op chemo and radiotherapy, then surgery. And T4, you treat it like T3, metastatic disease, only chemo, radiotherapy, and stenting.